We have a full agenda today, as like always. And before we begin, I would like to go over the guidelines during our virtual meeting. This is for members and staff who are on Zoom for this meeting. Members, please do stay on camera unless you have technical issues. That way our testifiers can see you. As is customary at committee hearings, please raise your hand to ask a question. On Zoom, the raise hand icon is located at the bottom of your Zoom window. Please mute yourself when you have finished asking your question or providing your comment. To everyone who has signed up to testify, thank you so much for participating and for providing your feedback. We will be starting with public hearing and then we will move into executive session. Once a bill is introduced, the testifiers will be moved to become panelists. Please do keep yourself off camera and mute until called to testify. After your testimony, please go ahead and mute yourself and take yourself off camera. Please feel free to stay until the entire panel is done testifying in case there are any questions from members. Members and staff can access meeting materials in EBB, and the public can follow along with the documents by going to the ledge.wa.gov website and looking for committee schedule. I would now like to ask Senator Wagner if he would like to introduce himself.
Thank you, Madam Chair. Pleasure to be here this morning. I'm Senator Keith Wagner, representing the 39th Legislative District, parts of Skagit, Snohomish, and King counties.
Thank you, Senator Wagner. And like I normally do, I forgot to introduce myself. My name is Manka Dhingra, State Senator from the 45th Legislative District. I'm so excited to chair this subcommittee. Senator Warnick.
Thank you, Madam Chair. I'm Senator Judy Warnick from the 13th Legislative District. Starts at Snoqualmie Pass and goes all the way to Spokane County line. So very rural district.
Thank you, Senator Warnick. Senator Nobles.
Thank you, Chair. I'm Senator Tawana Nobles, representing the 28th Legislative District. Thank you.
Thank you. And today we are going to begin our public hearing with Senate Bill 5397. And I would like to welcome Senator Randall to our committee. Very excited to hear your bill. And we will start with a staff presentation on this. And if I could ask the testifiers on this to be promoted to panelists so that we can get started with testimony right after we hear remarks from Senator Randall.
Good morning, Madam Chair, members of the subcommittee. My name is Kevin Black. I'm staff to this committee. Senate Bill 5397 relates to access to emergency behavioral health services. By way of background, when a designated crisis responder determines that a person meets criteria for involuntary commitment, the designated crisis responder has 12 hours to find a placement for that individual in a certified evaluation and treatment facility or secure withdrawal management and stabilization bed, or alternatively in a facility willing to accept the individual on a single bed certification. We've heard previously in this committee testimony that many of the most compromised individuals get turned away from placement in these facilities, even when there is treatment capacity available. Data from the Healthcare Authority indicates that as of last year, there was an average of 931 patients in emergency circumstances placed in single bed certifications per month, and an average of 46 no bed reports filed per month, which are reports filed when the designated crisis responder is unable to place that person within the 12-hour period and has to walk away from the commitment. What this bill does is it requires an evaluation and treatment facility or secure withdrawal management and stabilization facility that has treatment capacity to admit a person to the facility at the request of a designated crisis responder once that person has been detained for involuntary treatment, unless an exception applies. The exceptions are that the person requires medical services not generally available at a certified involuntary treatment facility, that a more appropriate facility has accepted the patient, that there are unusual reasons specific to the person that make the facility unable to admit the person, or that the services offered by the facility are specialized and the person is not among the specific population for which they are intended. The evaluation and treatment facility or secure withdrawal management and stabilization facility must also admit a person who is receiving temporary treatment at a facility pursuant to a single bed certification or provide, according to the same exceptions. If one of these facilities does decline to admit the person under the above circumstances, they must document that refusal and the reason for declining admission and provide that reason to the designated crisis responder within 2 hours of the admission request. If the designated crisis responder can't find a placement for the person, the designated crisis responder must immediately notify the managed care organization or behavioral health administrative services organization responsible for the cost of the person's care. The hold for that person is extended for an emergency 24-hour period, and the person must be provided access to a mental health professional during that extension. If the managed care organization or behavioral health administrative services organization is unable to find a safe placement or safe discharge for that person during that 24-hour period, the hold dissolves and the responsibility for filing the no bed report is transferred to that managed care organization or administrative services organization. The managed care organization or ASO is responsible for the cost of care of the person during that 24-hour emergency hold period. The Department of Health is required to review the documented denials of admission that are documented by the evaluation and treatment facilities and SWIMs, analyze the denials and determine if there are means for the facility to improve its ability to serve patients, including through the receipt of technical assistance from the Department of Health or other entities. Finally, effective July 1st of 2022, the evaluation and treatment and secure withdrawal management services facilities must develop the capacity to provide co-occurring disorder services within their facility, which means that the evaluation treatment facility would have to be able to provide medically necessary substance use disorder services to admitted patients. And the secure withdrawal management and stabilization facility would have to be able to provide medically necessary mental health services to patients within their facility. A fiscal note has been requested, but has not been received. I would be happy to answer any questions.
Thank you so much, Kevin. Do any of the members have any questions for staff? Okay, seeing none. Senator Randall, welcome. Would you like to speak to your bill?
Yes, thank you, Madam Chair. So good to see you all again so soon after our joint health care and behavioral health subcommittee meeting this morning. And you'll note that this bill is really responsive to some of the systemic challenges we talked about in this morning's meeting. For the record, I'm Emily Randall, and I am the senator from the 26th Legislative District on the Kitsap Peninsula, including Gig Harbor and the Key Peninsula. And this bill is before you again today because of one particular constituent story that's representative of the broader system. My constituent, Don Bremner, who I believe is also here today to speak, came to me in 2019 with a story about his son. His son was detained for involuntary mental health treatment in a facility with the temporary single bed certification after being refused to a certified evaluation and treatment facility. He stayed in that single bed certification for 100 days, despite his family advocating tirelessly for him to be transferred to an ENT facility. Don Bremner and his son's experience are not unique. Detained crisis patients so often struggle to attain admission to these certified crisis facilities. And sometimes, as Kevin said in the briefing, folks are even turned away when there are empty beds available. And most often, it's the folks who have the most complex needs who are denied these placements. In the last couple of years, we've made huge strides towards equity and accessibility in our behavioral health system, from our behavioral health teaching hospital, the Institute at Harborview, more and more work that you have led, Senator Dhingra, as well as these great members of the committee. But we have so much further to go. People with complex needs, such as Don's son, are still not receiving the care that they need and deserve. And that's why I'm back again for a third time introducing a version of this bill, Over the last 3 years, we have incorporated more and more feedback from community experts. And Kevin gave a comprehensive briefing, so I won't reiterate the details, but want to underscore how hard we have worked to perfect a policy to get closer to a solution that more folks will accept, including feedback from the experts who participated in the Behavioral Health Recovery System Transformation Task Force. I'll also acknowledge that there continue to be concerned critics of the policy before us. The Washington State Hospital Association has concerns I'm sure they'll speak to, and they're also undergoing their own work to try to find solutions that meet the needs of a system that, frankly, part of the challenge is we don't understand how complex the needs are before us. So I appreciate Wisha's testimony, appreciate the testimony and concerns from the Office of the Developmental Disability Ombuds about the involuntary treatment system more broadly, and look forward to hearing more feedback so that we can get closer to Washington that is able to be responsive and meet the needs of individuals in crisis so that those crises don't escalate. Thank you so much. I'm available for questions and look forward to working with you on this policy.
Thank you so much, Senator Randall. This bill does highlight an issue that people all across the state deal with and it is unfortunate that we have this issue in our state. And I really do appreciate all the work that you have put in trying to develop a solution. And I know we've been making strides, and I think we have to continue to push to make sure that we end up getting the result that we all need and want. So thank you for this work in this area. Do any members of the committee have any questions for the senator? Okay, seeing none, we are going to move into testimony, and Senator Randall, you're welcome to stay. But I also know that you probably have a lot of other needs that you need to attend to. So first, I'm going to call Donald Bremner to testify in front of the Behavioral Health Subcommittee. Please do put yourself on screen and unmute yourself, identify yourself and start. And welcome back to the subcommittee. I think we wanted Donald Bremner. Okay. Dimitri, we will start with you then. You'll have to unmute yourself and identify yourself.
Thank you very much. And hello, thank you for the opportunity to testify today. I'm here today as a physician, psychiatrist, and chief medical officer of Comprehensive Life Resources, a community-based mental health organization in Pierce County that cares for many individuals with serious mental and physical health conditions. While we appreciate the goals of SB 5793 to facilitate timely care for individuals in a behavioral health crisis, my organization and I have some concerns about it as it's currently written and worded. And at times, designated crisis responders are compelled to detain an individual who's in a behavioral health crisis outside of an emergency room or other healthcare setting. And as currently written, SB 5793 does not require a medical evaluation of that individual in that circumstance if they're found to be meet involuntary treatment authorization criteria, and requires that a freestanding evaluation and treatment facility, many of which lack important medical capabilities, accept the individual as a patient, unless one of those specified exceptions are met. And there are many serious medical conditions, some of which are life-threatening, that can present as a behavioral health emergency and which can't be managed safely in a freestanding behavioral health facility. And delays in proper care due to having to transfer an individual to a community hospital can lead to a potentially fatal outcome. Years ago, as a psychiatry resident in the emergency room at the Johns Hopkins Hospital, I was part of a team treating an older man. His family had brought him to the ER because he'd been hallucinating and had lost the ability to care for himself over a span of 2 weeks. He was nonverbal. He became unresponsive very quickly with a diastolic blood pressure too low to detect and required CPR. The man survived, and the cause of his behavioral health problems were being pneumonia, and which had led to sepsis. But fortunately, he was brought to an ER in a large hospital teaming with emergency medical staff and specialists. I wonder what would have happened to this man if his treatment was governed by SB 5793 as currently written. And instead of taking him to the ER, his family had called the crisis line, and a designated crisis responder had detained him, leading to his admission to a freestanding facility rather than the ER where he belonged. And this example illustrates one possible potential worst case scenario that SB 5793 as currently written could create, and which cannot be allowed to happen. And I thank you for allowing me to testify.
Thank you so much for that. And Donald, I'm hoping that you can unmute yourself. And
I did. Can you hear me?
Yes, I can hear you now. Thank you so much.
Okay.
Are you able to come on video? And if you're
let's try that.
Oh, there we go.
Okay.
Thank you so much. Please do identify yourself and start.
All right. Thank you, Madam Chair, members, including Senator Randall. I am Don Bremner. I live in Gig Harbor, and I thank you all for being there under these strenuous conditions. But since you are there, we all expect you to do good things. And passing this bill would be a very good thing. As a caregiving father to a schizophrenic son, I see this as a very helpful and long-awaited improvement to the state mental health law. I did see the shortcomings of the law, as indicated by Senator Randall, when my son was detained for involuntary commitment under that law. I won't go into some of the details that Senator Randall provided, but seeing all of this happen, I wondered how, in a procedure where the promise of treatment justifies legal detention, the provider of that treatment had the discretion to refuse it. Todd, my son, was eventually admitted to an ENT. However, after sending him to an ER to check out his blood pressure concerns, and because he had a physical fall at the facility, the ENT refused to take him back. So after 4+ months of seeking emergency treatment, the system left him in limbo without it. The bottom line is that Todd never received treatment under the state system. I'll leave how he actually did recover to your questions or to some other time. By contrast, we once lived in Hawaii, a small state in the middle of the ocean. Todd was involuntarily hospitalized there several times, and at no time did he ever come close to waiting 4+ months for treatment, and at no time was he refused treatment. This bill will help eliminate the short circuits that exist in the state system. These glitches prevent people from getting emergency mental health treatment in a timely fashion. It also provides some oversight to the management of this system to make it better. So I ask you, please pass it. Thank you.
Thank you so much, Donald, for taking the time to come yet again to testify in front of our committee. And we have heard from other family members about the exact same problem that you're describing. So thank you for your advocacy. I would now like to invite Daria Farivar to please identify herself and start her testimony.
Thank you. Excuse me. Thank you, Chair Dhingra and members of the committee. For the record, I'm Daria Farivar with Disability Rights Washington. We have signed in other to 5397, and I want to thank Senator Randall for bringing this bill forward. We have been concerned for quite some time that individuals who have disabilities, in addition to behavioral health disabilities or complex needs, are being denied placement in certified evaluation and treatment facilities that do in fact have beds available to serve them. DRW has received many reports similar to Mr. Bremer's reports on folks with developmental disabilities, dementia, and other disabilities being stuck in single bed certifications in hospital emergency rooms after being turned down by ENTs. When these patients are denied admission by the ENT facilities, it fuels the need for and the reliance on single bed certifications in facilities that are more restrictive and incapable of providing adequate care and treatment. We are very supportive of the requirement that ENTs document why they are declining services to individuals so we can learn why so many people are landing in these single bed certifications. Section 21A states that the reason ENTs may cite for denying services, one of which is if an individual requires medical services not generally available at a facility certified under this chapter. We worry that this language is too broad, as we've heard reports of individuals being denied services for having needs such as a CPAP machine for their sleep apnea. This section simply provides further explanation for what is currently in statute, and we would appreciate some stronger language on 21A. Section 3 sub 2 creates the ability to hold an individual for an additional 24 hours on top of the 120-hour initial detention by DCRs if an ENT bed is not found. We are unclear why there is an additional 24-hour detention, and it seems as if the hold is simply to allow for systems communication. And if that is the case, we do believe we should be addressing those communication issues rather than detaining individuals to allow time for that coordination. We urge you to strike Section 3 and focus on streamlining the process so individuals are not unreasonably and unnecessarily detained. Thank you for the opportunity to testify.
Thank you so much for that. And I'm sure there'll be written testimony following with those details that we can take a look at. Next, I would like to invite Jacqueline Greenberg to please testify.
Thank you, Chair Dingra. Good morning, everyone, members of the committee. For the record, my name is Jacqueline Greenberg. I work on behavioral health policy on behalf of the Washington State Hospital Association. Before we get into the testimony here, I just want to acknowledge Donald Brenner's advocacy in the area. We've exchanged emails over the years on this bill and others, and I appreciate very much his work in this space to help us improve the system, and to also state very clearly that the Washington hospital community shares very much the goal to see every single person receive the right care at the right time in the right place. Unfortunately, we do not believe that this bill will do that. And so we are here in opposition to Senate Bill 5397. And we ask that this committee not vote this bill out of committee. There are several reasons for our opposition. First, we do not think that this bill will work the way that it thinks that it will. The bill pivots around this notion of certified facilities treatment capacity. And I think that it presumes that there's a lot of treatment capacity to be found. And I think when we think about something on an individual case basis, yes, I think we can imagine that there is a bed here and there to be able to do that. But on a statewide systems level, there is none. And we know that Kevin just pointed out the average single bed certification numbers are near 1,000. The no bed reports are 46 on an average month. And let's remember, single bed certification is a stopgap measure. It's a temporary license for a single bed for a patient who requires care, whose crisis calls for services that cannot be found. Now, we can debate what those services are, but we need to recognize that right now there is no treatment capacity in the system, and it's about to get worse. The governor is proposing to close 330 beds in the next biennium, and only a fraction of that is being reinvested into the community system. So that means, practically speaking, what this bill does is it requires all hospitals, regardless of their ability to meet the single bed certification standard, to hold a person for an extra 24 hours in the emergency department. And this leads to the next problem. This bill creates a mandate on hospitals that is plainly in conflict with the law. In 2014, the Washington State Supreme Court ruled in re DW that the Involuntary Treatment Act does not authorize boarding, holding someone in one place because there is no space available in an appropriate setting, simply because there's no room at a treatment facility. This is precisely what this bill asks us to do. There's other reasons why we oppose this bill, which I will provide in writing. One piece that I want to emphasize here is, again, going back to that plan around closing $110 million worth of civil state beds. It does not have corresponding investment right now. In particular, it thinks about capital funding as opposed to operational funding. We have a workforce problem here in the state right now, and this bill presumes that there is none. It would require hospitals to provide 24-hour access to a mental health professional. 60 out of 110 hospitals in the state in 2019 and 2020 were able to meet that requirement. This bill also requires co-occurring disorder services. There is one facility in the state right now that is licensed to provide that service, one. There are not enough behavioral health professionals here. We need policies that concentrate on that. Having said that, doing nothing is not an option, and we know that. And Senator Randall raised that bill, and I want to acknowledge, we have spoken with Senator Randall, we have spoken with stakeholders on this issue. We know something needs to change. The system is not working, and we want to be a part of fixing it. Before I go on, may I just take one more minute to talk a little bit about the data project?
Yes, 1 minute.
1 minute. Okay, super fast. And again, I'm going to put details of this project that we have in written testimony after this. The bottom line here is we think that increasing access to behavioral health inpatient services has to start with data, because not all people's involuntary treatment needs are alike, yet we treat inpatient beds as though they are. As a statewide system, we cannot answer the questions that this bill poses. What are the specific treatment needs of a person who can't find a bed? And what is ENT's specific treatment capacity that makes them feel like they cannot accept that person? So what WISHA and our behavioral health hospitals are doing right now this year is we are going to develop recommendations based on data that we collect to answer those questions. We want to provide those recommendations to the legislature with input from stakeholders. It's a big undertaking, especially in the middle of a pandemic, but we're committed to it. We really want to be here. We want to be a part of the solution. This bill is not there yet. Thank you very much. I'm happy to answer any questions.
Thank you, Jacqueline. I actually look forward to taking a look at that data along with those recommendations. Next, we're going to hear from Dr. Ryan Kay, and I apologize if I pronounce your last name wrong.
Thank you very much. Thank you, Chair Dhingra, and for this opportunity. I'm Dr. Ryan Kay, just like the letter K. I'm a practicing emergency medicine physician and also the medical director of the emergency department at Providence and Everett. Today, I'm speaking on behalf of the Washington chapter of the American College of Emergency Physicians, and we represent emergency providers across the state in small and large hospitals alike. And thank you for hearing our voice. I think this is a really important issue. Behavioral health and substance use disorders are really critical issues in emergency medicine, and it's something Washington ACEP is passionate about. We are the front porch and the safety net for patients in crisis and needing care, and we recognize the limitations of our current system of care for our patients in crisis. However, we are in opposition to 5397 because we don't believe this will fix the problem currently. The volume of patients in mental health crisis presenting to an emergency department is on the rise. In 2020 alone, our emergency department took care of an average of 340 patients a month requiring mental health evaluations. That's more than 11 patients every day in acute crisis and 1,200 patients a month that meet CMS-defined mental health condition. The burden of the pandemic on top of access to care has been tremendous. The requirement to hold a patient in the emergency department for 24 hours while DCRs work on placement will overwhelm even a well-resourced department. For our small and critical access hospitals, it will completely tank operations and throughput. It will incapacitate a department and their ability to care for all patients in both medical and behavioral health crisis. In our facility alone, our current average length of stay is 1,074 minutes. That is almost 18 hours for a behavioral health patient. This is a 40% increase since 2018. And despite active work, we've partnered with the Institute for Healthcare Improvement and other organizations to decrease length of stay, improve throughput, and improve the patient experience. However, there have been a lot of systems issues in the state of Washington that have made it very difficult to provide timely and appropriate care. And in keeping with that quadruple aim that Jacqueline cited, getting the patients to a therapeutic environment in the right place. So we understand that the spirit of this bill is to get the patients to that best, most appropriate therapeutic setting. However, we don't think this will accomplish that goal. I guess I would ask, and I think that the story that was told about, not not having the ability to get timely care for an acute psychosis was really moving and important. And I would also ask committee members to think about what it would feel like to be in that acute state of decompensation, whether you've lost all meaning in life and want it to end, or you're acutely psychotic, and then be held in an emergency department room for days while there's an indeterminate endpoint and destination for you. Would you feel cared for, or would you feel marginalized in that situation? Pushing access issues back into the emergency department is not the right answer at this point. And I really think we need more data to understand the gaps in order to be able to close those gaps. Thank you very much.
Thank you so much, Doctor. I do understand the challenges that you guys are facing, but and I'm glad that Jacqueline said they're trying to work towards a solution, because for family members and individuals that are struggling, getting help and access to help is key. And we as a state, unfortunately, are not at the level that we need to be. But thank you for the work that you do, and especially during the last few months, the last year. I know it's not been easy, and thank you for that. Next, I would like to hear from Noah Seidel, and we'll follow that up with Chris Bandoli and
Good morning, Madam Chair and members of the committee. My name is Noah Seidel, and I'm representing the Office of Developmental Disability Ombuds. The DD Ombuds has signed in other to Senate Bill 5397. Thank you all very much for considering this piece of legislation that people with developmental disabilities can benefit from who are currently stuck in hospitals. The DD Ombuds has worked with people who are being denied placement in certified evaluation and treatment facilities because of their developmental disability. This has caused people to have extended stay in general hospitals, and there has been incidents of restraints being used against people with developmental disabilities in these hospitals while they're waiting to go to an ENF facility. The DD Ombuds has also worked with people who have had issues with finding a safe discharge out of hospitals and facilities. We support that this bill has the managed care organizations and behavioral health administrative service organizations working on a safe discharge. This will hopefully help people with developmental disabilities find a safe place for them to discharge to and help with that process. Thank you very much for considering this bill, and have a good day.
thank you so much for testifying. Next, Chris Bandoli. Good afternoon. Good morning.
Yeah. Good morning, Chair Dingra and members of the committee. For the record, Chris Bandoli here on behalf of the Association of Washington Healthcare Plans, and in particular for this legislation, the 5 managed care plans offering service to the Medicaid population in our state. We're signed in other on this legislation. We do appreciate the intent of the legislation, and we think it does make some steps in the right direction. But perhaps, as you've heard in some of the previous testimony, we don't believe it necessarily fixes the inherent flaws in the crisis system as a whole, and therefore its impact could be limited. We also do have some more technical concerns that I'll go over shortly. On the positive side, we think the requirements for ENTs to accept transfers from single bed certifications could be useful, although we are a little bit concerned that some of the loopholes put in could undermine that success a little bit. We also do like the requirement, given the rate of co-occurring conditions, for the ENTs to provide SUD treatment and for the secure withdrawal facilities to provide mental health treatment. Although we think this will be a big lift for the facilities, we think it is a step in the right direction. On the concern side, there's a lot of notification requirements flying around in the legislation or flying around between entities. The MCOs need to be included in these notifications, as they report that they're often left out, or at least the notification comes late. For instance, their knowledge of the expiring 24-hour hold is dependent on getting timely notification from providers and DCRs, and this is not always currently happening. All the information the bill would have them required to send to the HCA in a report is very dependent on other stakeholders sending us the available phone call for the information we need, and again, it's not always the case. It's worth noting that the MCOs don't have direct interaction with the DCRs most of the time. It's something that the ASOs oversee. They receive notification for the PA after a facility actually accepts the ITA member. So it'd be a pretty big process overhaul that would add a lot of administrative burden for both the MCOs and the ASOs moving forward. They also note that they don't have staff on weekends, so they can't necessarily submit reports or place patients within 24 hours. They also are concerned that shifting the DCR responsibility to find beds for members to the MCO might be seen as the MCO's directing care, which is something they're not permitted to do. And then the last concern that they have is that they don't see the requirement to engage for 7 days with individuals who can't be placed as likely to help solve the problem. These are individuals who've refused treatment, and we think it will impose significant costs without necessarily yielding a commensurate benefit. So these are some, I read those because they're pretty technical and I wanted to be sure I stated them properly. We appreciate the legislation, we appreciate Senator Randall bringing it forward, and if the committee decides to move forward, we'd love to talk about how to ameliorate some of those concerns. Thank you.
Thank you so much, Chris. Brad Banks, you're up next.
Chair Dingra, good morning. Ranking Member Wagoner, thanks so much for the opportunity to testify on 5397, and a big thank you to Senator Randall for continuing to work on this bill. We know it's a bit of a labor of love and a big piece to have to kind of encapsulate and continue to work on. And I think what we see particularly in this bill, as we've seen from other bills, this really highlighting the need for significant increased investments in our crisis system. That is just, I know this is the fiscal committee, but just to plug there that this really does dovetail with so much of that. That said, we are signed in other on this legislation, and I think for a lot of the reasons you've already heard, there are some technical and frankly just some wording issues that I think we could continue to work with the sponsor and others on. Primarily, ASOs agree that Section 3, the 24-hour hold, is problematic, and we would like to see that removed from the bill. I think there's other ways to probably address that. Additionally, our designated crisis responders do tremendous work, and when there is a placement to be found, they almost always find it. Unfortunately, there is not always that is not always a possibility because of community availability. And likewise, the bill reads, there's one section we're particularly kind of concerned about that seems to require DCRs to deliver that hold order from Section 3, which would obviously be mooted if we got rid of Section 3, but to deliver that hold order in person. And I think this could be extremely burdensome and really divert DCR availability in the system. And we already know we have an insufficient workforce as needs are continuing to grow. Additionally, the requirement for EMTs to provide co-occurring services is a fantastic goal, and we would love to see that and continue to work to see that happen. Unfortunately, most facilities at this time just aren't certified for that. And we do believe that there, especially with the timeline put out in this bill, a significant cost associated with staffing, licensing, and modifying every facility in the state to meet that capability. And finally, the requirements in this bill are just not very workable in our view from large rural regions where distance and availability for services is much different. This is compounded by limited resources available to rural community hospitals, many of which our rural regions do not have staffing or resources for single bed certifications or the ability to provide behavioral health treatment. So as you can see, we have a number of things we would like to work with the sponsor on. We do have some amendment language that we think we could put out there to help this along, and agreed, this is a fine goal and something we should be continuing to work for, but we would like to try to do some changes if possible. Thank you.
Thank you so much, Brad. I look forward to reviewing your written changes. And with that, I would like to invite Carrie Reardon to please come testify.
Good morning, Madam Chair, members of the community. My name is Carrie Reardon, and I'm here today on behalf of the Washington Defender Association and Washington Association of Criminal Defense Lawyers. We are opposed to this bill for a number of reasons, and I think the main reason is that we are continually to fail to provide what is needed. This doesn't provide any real change to what is currently in place. Until we have the necessary number of mental health beds, the necessary number of detox beds, and enough trained counselors and social workers on the streets, we're never going to really address the issue that bring people into our system. It's a Band-Aid on something that is hemorrhaging, and it is not an efficient use of legislation to do so. We are very concerned by the addition of adding 24 hours if a person is held on a single bed certification. We are already at a system where we have 120 hours of involuntary detention before a person sees the court. This simply adds to that stay and denies a person access to the judge and review of their case. We're also very concerned by the mandate for mental health facilities to provide chemical dependency treatment and chemical dependency facilities to provide mental health treatment without any indication of necessary training or expertise in that area. I certainly cannot imagine that any of us would send our loved one to the foot doctor to deal with a cancer diagnosis. And this seems to be doing just that. We're not fixing the problem, we're creating further problems. Of additional concern, I certainly appreciate the idea of getting people off of a single bed certification within 24 hours. But what this bill said is that the single bed certification dissolves. It doesn't say the person is then released and sent home. It just dissolves, which presumes that the process is going to start over. So we could wind up on a never-ending cycle of somebody still being too ill to leave, but not able to find placement. And so we're not fixing the problem. I find it absolutely abhorrent to hear about an individual who was on a single bed certification for 100 days. Certainly, the court should have been doing something about that individual. But until we properly fund our mental health system, we cannot expect that this is going to be the change that is needed. I certainly know that change would be helpful, and I encourage the legislature to find that, but I really suspect that's going to come with a large fiscal note. Thank you.
Thank you so much, Carrie. Next up is going to be Angie Naylor.
Thank you, Madam Chair and members of the subcommittee. I'm Angie Naylor. I'm the Chief Nurse Executive and Quality Officer for Multicare Behavioral Health and also representing the Washington Council for Behavioral Health, the statewide association of licensed community behavioral health agencies. Many of these agencies, including Multicare, operate evaluation and treatment facilities for people who have been involuntarily committed. Some of them also run designated crisis responder teams in their counties. We have concerns with this bill as it's currently written. We take our role as part of the safety net system as well as our admission decisions very seriously. We consider whether we can truly meet the needs of an individual and do so in a way that ensures their safety and that of other patients and staff. In fact, we rarely decline an admission unless we believe we cannot meet the person's specific needs or there is a significant safety risk for that person, other patients, or our staff. There is also a financial component. If beds are empty, we don't get paid. And because ENTs are only 16 beds, many are budgeted pretty much full census all the time. That's the only way we can make finances work. However, facilities must still have the right to decline admissions on a case-by-case basis in order to manage safety for their patients and staff. We are very concerned about delineating prescriptive exceptions in the statute as it would jeopardize our ability to do that. There could very well be a scenario that doesn't fit squarely into one of the 4 boxes on the form. Examples could be a difference of a medical facility and ENT around medical clearance and the medical services that can be offered within that ENT. Regarding the requirement for crisis facilities to provide co-occurring disorder treatment, I just don't know how we will have the necessary workforce to do so by July 2022. Low Medicaid reimbursement rates make it impossible to pay the salary and benefits needed to recruit and retain a workforce in the community behavioral health system. Most providers across the state are already struggling to keep qualified staff. If we don't have staff, we can't treat patients. Finally, and most importantly, we will never have enough inpatient beds if we don't start making significant investments in upstream preventative behavioral health treatment. One solution to improving the crisis system is to help the people sooner in the course of their illness. Thank you for the opportunity to testify. I'm happy to answer any questions.
Thank you so much, Angie. Next up is going to be James McMahon.
Thank you, Madam Chair. Happy Friday to you and to the committee. I'm James McMahon, Policy Director with the Association of Sheriffs and Police Chiefs. We're here signed in other today, but I do want to say we would otherwise support every provision in this bill, save for one that I want to discuss. And let me first thank Senator Randall for her work on this effort and for this committee's ongoing support of that. We fundamentally believe that we as a government should provide help to those who need help. And to that extent, this bill seeks to accomplish that. There's one provision, however, and it comes in section 3, subsection 3, the last sentence there. And it talks about if an MCO or BHASO is unable to find a bed for an individual in their custody or in these circumstances, after that 24-hour emergent extension period concludes, it allows the person to be simply discharged and the hold shall dissolve. And that's the concern that we have here. And we certainly are willing to acknowledge that that may be happening already. And we would say that's a problem as well. These are people who by definition have been found a danger to themselves or others. And we think it's incumbent upon us as the system to provide help to those who need help and simply not allow the circumstance where a person who is identified to need help just simply gets discharged because we have trouble finding a bed. We recognize there's many complexities of the system that we don't have the expertise to understand, but we ask your assistance in ensuring that we give help to those who need help. Thank you.
Thank you so much, James. And next is going to be Stephen Pierce.
Thank you, Chair Dingra and committee members. My name is Stephen Pierce, and I'm the director of the Citizens Commission on Human Rights, and we are a psychiatric watchdog organization. SB 5397 starts off by saying that some of the adults and children experiencing behavioral health crisis, are unaware that they have a brain disease. And this statement, we feel, stigmatizes the mentally ill and blames them for the ineffectiveness of treatment and ignores science that tells us why people refuse and stop taking psychiatric medications. According to one of the most important studies of antipsychotic drugs, the National Institute of Mental Health found that 74% of the patients quit the antipsychotic drugs they're taking owing to inefficacy or intolerable side effects for other reasons. Nowhere in this study did it state that patients stopped taking their drugs due to their mental condition or that what they were doing was fine until they went off their meds. Antipsychotics are generally effective for only a period of time, a few months, 1 to 3 months, according to one major study. So while we are also against the extended holds and some other comments that people make of preventive care earlier in the community, I mean, there are non-toxic, what we're talking about in psychiatry, mostly in the mental health system, are toxic solutions. We're giving treatments and drugs that people resist and aren't responding to. The system does not deal with people well who want alternatives and who would respond to non-coercive methods. I think that's a whole hole in the mental health system that needs to be addressed and should be looked into further. There are lots of medical reasons why people experience an emotional crisis. There are resources for these that the system could already be utilizing that wouldn't just impact the mental health system. And there's a lot of promotion and a lot of gain that could be had by the system recognizing that. And, you know, the state isn't married to the psychiatric industry to dispense drugs. And the state needs to move away from that position and start looking towards what citizens want on a broad basis, not just what the psychiatric industry wants. And I feel until we do that, you're going to be stuck in this position of trying to have providers and trying to create a system that is kind of stuck under its own weight, and you're not recognizing the treatment failures that occur within the system. That's continually what I've heard over the last 20 plus years, is the system trying to deal with its treatment failures. So I think those issues need to be addressed, and we advise that this bill be modified or not move forward.
Thank you so much, Mr. Pierce. I do want to thank Senator Randall for bringing this bill forward. She is trying to tackle a huge issue in our state. I want to thank everyone for testifying on this matter. I think one thing that all of us heard very clearly is the lack of appropriate beds for individuals who want and need that care. The state of Washington continues to rank one of the lowest in terms of hospital beds per 1,000 people. And so a lot of work ahead of us in that regard. And with that, I'm going to close the public hearing on Senate Bill 5397 and open the public hearing on Senate Bill 5370. I would like to welcome Senator Kaiser to this committee, and thank you so much for your patience while you waited for testimony to end, Senator Kaiser. And if we can start with a staffing report from Kevin.
Good morning, members of the committee. Madam Chair, for the record, I am Kevin Black. Senate Bill 5370 relates to mental health advance directives. A mental health advance directive is a document that declares a person's preferences regarding the person's mental health treatment in the event of incapacitation. Washington State's mental health advance directive law was passed in 2003. Advance directive may include preferences and instructions for mental health treatment, consent or refusal for certain specific types of mental health treatment, consent to admission to a facility for mental health treatment for up to 14 days, or appointment of an agent to make mental health treatment decisions on behalf of the person when they are incapacitated. A mental health advance directive must be signed by 2 witnesses who know the person and attest that the person does not appear to be acting under incapacity, fraud, undue influence, or duress. A healthcare provider must act in accordance with the terms of the mental health advance directive to the fullest extent possible unless compliance would violate an accepted standard of care or an exception applies. What the bill before you would do is it would amend the pattern form which is provided to create a mental health advance directive in a number of ways described in your bill report, including streamlining and simplifying certain language in the body of the form. The bill would also allow the mental health advance directive to be acknowledged before a notary public instead of being witnessed by 2 adults. It would also allow a person who is 13 to 17 years of age, if they have capacity, to execute an advance directive. Provisions stating an agent may act on behalf of the principal with respect to healthcare information are changed to specify that the agent may act as the principal's personal representative for the purposes of HIPAA, the Federal Information Privacy Law. And finally, references to mental health are changed to behavioral health within the context of conditions which could trigger the provisions of the Mental Health Advance Directive. And a substance use disorder professional is allowed to participate in an incapacity determination for the purpose of invoking the directive under the same circumstances in which a mental health professional would be able to participate in those proceedings. A fiscal note has been requested but not received. I would be happy to answer any questions.
Thank you so much, Kevin, for that briefing. Do any members of the committee have any questions for staff? Yes, Senator Wagner.
Thank you, Kevin, for briefing that. I'm curious about the provision for 13 to 17-year-olds. Are there any caveats on that? Like they don't have a designated adult who would make a decision like that for them or help that with that decision? Or does it just blankly state if you're 13 to 17, you can enter?
It says that the adolescents who are 13 to 17 can execute a directive if they, have the ability to make informed decisions relating to healthcare. There is a presumption of capacity that applies to adults, and the presumption of capacity isn't applied to the adolescents, but they are allowed to do it if they are able to understand the consequences and engage in informed decision making around their behavioral health care.
Okay, thank you.
And just to follow up on that, Kevin, could you just speak about issues regarding age of consent in terms of behavioral health care in the state of Washington? Because this bill does not make any changes in that regard, correct?
Sure. Yeah, the age of majority in Washington is 18 years old for most purposes, but we do have a lower age of majority for the purpose of making decisions related to behavioral health care, which is 13 years old.
Thank you for the clarification, Kevin. Does anyone have any additional questions for staff? Okay, seeing none. Welcome once again, Senator Kaiser, and thank you so much for bringing this bill before us. And I just want to thank you for the work you did on the original mental health advance directive in 2003, and thank you for the follow-up.
Thank you, Senator Dingra. Thank you for hearing this bill. Thank you for discovering my old bill. which had I worked really hard on. And I tell you, I want to go back to those days because I remember I was out in my neighborhoods knocking on doors, and I had this intense conversation with one of my constituents about their young adult son who was schizophrenic and how he would occasionally decompensate. When he stayed on his program, he was stable and productive. He had pets, he lived independently, but when he decompensated, everything went sideways. And they heard about advanced directives and thought it would be really helpful for people like their son. So I started working on it, thinking it would be simple, and along with NAMI. And oh my goodness, this is difficult work. It is difficult to thread all the needles. We finally got the bill passed in 2003, but it hasn't been implemented quite as intensively as it could be. I think it could be much more useful. And I really appreciate you spotting that and helping us update it and make it more contemporary and appropriate. And I want to thank you for your good work on this too. Thank you. I urge the committee's support for this measure.
Thank you so much, Senator Kaiser. Does anyone have any questions for the prime sponsor? Okay, seeing none, you're welcome to stay for the rest of the hearing, but I am sure there are lots of other demands on your time.
Thank you very much.
And with that, I would like to invite Lisa Brodoff to please identify herself and start her testimony.
Thank you, Senator Dingra, and hello, Senator Kaiser. I had the opportunity to work on the bill as is in 2003 and was honored to work on it with Senator Kaiser. And I think that bill passed in its first session unanimously, which is a minor miracle. So I'm really excited to be able to speak in favor of SB 5370, which makes simple but really major improvements to what was an excellent law, right? So just to give you some background, I'm a professor of law and I direct the clinical law program at Seattle University School of Law, and I teach and practice in the area of elder law and disability law for 40 years. So I've had a lot of experience working with clients and working on this legislation, and this is a very excellent improvement. So let me tell you what I want to speak to is the improvements in the Mental Health Advanced Directive statutory form. When we met with the subcommittee back in December, we identified the problem with the current form, which is it's overly legalistic, it's too long, it's very densely worded, and it leaves out some really important information and planning opportunities. And it's really hard for providers to implement, to find the important language and to implement it. So that's what we worked on, and David Lord and I and the Senate staff drafted what is now the new form in SB 5370. And we took what we learned from peers, comments, and also our own experiences working on end-of-life advanced directives, living wills, to make that form much easier to draft for clients and easier for health providers to read it, to find the important information, and to implement the directive of the patient. So here's what 5370 improves. It makes the form much shorter. It cuts out all of the paternalistic warning language that took up almost 2 pages of language, single-spaced in the directive, and it goes right to the core message of the advanced directive. So then after cutting that out, the form now has a new section right at the top that is easy to find, and it allows clients to describe their diagnoses, both physical and mental health, to tell what prescription medications they're on, what their care preferences are and their values around healthcare, mental health care, and then add it in their substance abuse history and options there. This critical information was entirely missing from the old statute. Well, what I should say is the current statutory form, and it's a really big and simple improvement that's in this bill. And finally, the new form simplifies the language and choices in the remainder of the form, making it shorter, more user-friendly, and easy to follow and find. So these simple changes in SB 5370 will make big improvements in what's already very strong but underused and followed mental health advance directive statute. And I strongly support the passage. So thank you for giving me this opportunity.
Thank you so much for your testimony. And I really do want to thank you for all the work you did during the interim in meeting with the behavioral health work team to figure all of this out. Does anyone have any questions for Lisa Bruto? Okay, seeing none, I would like to invite Laura Van Tosh to please come and testify.
Thank you very much, Senator Dingra. Good afternoon, good morning, and I'm glad it's Friday. I just want to say that I appreciate the work put into this process, but I hope to be in contact with Lisa as well afterwards. Just really quickly, I want to acknowledge Senator Nobles. I am really happy that she's part of the Senate. It's Black History Month, and she most clearly and visibly is making history right now and will. So I just really appreciate her participation in our legislative process. I also, with Lisa and others, participated in the interim on this process, and I had an advance directive in the state of Oregon, which unfortunately was not followed for many reasons why most people with behavioral health care issues sort of laugh them off or don't want to complete them and don't find them effective. And so therefore, they're woefully underutilized. And I really hope that we can take a bit more time. The interim group had a few people with behavioral health care issues, but certainly more of a dialogue about that would be very helpful in the future. And I also wanted I forgot to say that I do support this bill, but I do think that there needs to be possibly some amendments considered. First of all, the behavioral health system now is inclusive of substance use disorders, and I think that's a whole new group of people that we really need to hear from, and I don't know that they were represented during the interim in terms of their preferences and issues around advance directives. I look forward to completing an advance directive when I know that it will be, quote, heard and respected and acknowledged should I have a behavioral health care crisis, which certainly is possible. People think that it may not ever happen again, but you never know, and I certainly did not know when it happened to me within the last several years. One thing within the advance directive that I do appreciate is that it is to contain a full range of choices. However, we don't really have in our behavioral health care system a full range of choices. And so I really want to encourage that the advance directive process and tool be actually considered, as Lisa sort of alluded to, as a planning tool itself, and that we actually track what's not available, but requested in our system, but requested an advance directive and not available. And also start tracking what is requested, because I think those are the things that we may want to consider incorporating in our behavioral health care system that we don't have. Typically, things are requested within directives, and I know my own, that are not part of the system. I didn't request yoga, but certainly yoga could definitely be something that I request instead of perhaps an involuntary measure of some kind. It could be requested instead of medication, perhaps. So there's a whole host of opportunities here, and certainly other clinical services that we don't offer now in our system that could be requested, that we should be tracking. If tens of thousands of people are requesting something that we're not offering, and it's not part of the Medicaid benefit that we offer, why not include it? Why not recognize that this is something that people actually want? I just clicked the button here by mistake. I'm sorry. Anyhow, that is my testimony, and I appreciate all the work. I did want to add one thing for Senator Kaiser. You made reference to someone who is, quote, schizophrenic. And I just wanted to say that there's person first language in the behavioral health care arena, that people first language or person first, which is the gentleman that you referred to as a gentleman with schizophrenia, not a schizophrenic. And I think that that's something that I hope maybe we take a page from, and there's literature about this and information about how we make reference to people with psychiatric disabilities. Thank you again.
Thank you so much, Lauren. Your point is very well taken. I think there definitely is very interesting testimony regarding the desire for treatment and the lack of treatment, and being able to track that so we can really start offering treatment that we now know that people want. So thank you for that, and thank you for your work all during the interim on this committee. Next, I'm going to ask Jacqueline Greenberg to please come testify.
Yes, good morning again, Chair Dingra and members of the committee. For the record, my name is Jacqueline Greenberg, and I work on behavioral health policy on behalf of the Washington State Hospital Association. First, I want to thank Senator Dingra, you for your really incredible leadership, bringing all of us together. The work group that was contemplated here was originally in bill form, and I appreciate that you did not let that bill stop you or stop us from coming together on this really important issue. I think there's a lot of work to be done here, and I appreciate it very much to have the opportunity to contribute to the discussion. I also really want to again thank everyone who participated in those meetings in the fall, and especially in particular Laura and the other individuals who shared their own experiences and traumas, including family members like Jerry Clark and Todd Crooks, all with a view to helping others and helping us all as a system do better. We're here in support of the bill. We're really, we appreciate the opportunity to have participated in those meetings and to work with Lisa and others, and look forward to continuing the work going forward. And I want to acknowledge that we in the provider community know that a big part of the work is not about how the law is written, but about improving the implementation of the law, raising awareness, interest, and understanding of these documents. And WISHA is doing the work now and working with our provider partners about how we improve implementation of that, so that when someone comes into a hospital with a mental health advance directive, that they are met by people who know how to read it and want to rely on it. About this bill, among other things that we like about it, we definitely appreciate that reworked form. Doctors are not lawyers, and it is going to be helpful to have something that is friendlier to be able to read, especially in a crisis when things are moving quickly in a very pressurized environment, to have something that will help. We do have 3 changes to the bill we hope to see move forward. They are small, but they are mighty. The first change that we want to see is in the form. We would like to see reference to people being able to receive treatment from physician's assistants and advanced registered nurse practitioners in addition to physicians. That's how the existing law works. It's consistent with the Involuntary Treatment Act and other statutes, and it's an important means of just increasing access to services, recognizing that, of course, not everyone has access to a physician when they're receiving these services. The next change we want to see is in relation to that HIPAA authorization. I won't bore everyone here with the specifics of how the myriad of health privacy laws work. They don't work especially well. So we just want to have language in here that recognizes that there are other statutes at play here, and make sure that we read them consistently to ensure that there's no confusion, that we really want to see people get access, people who are helping to execute the advance directive get access to that information. Finally, we want to see family-initiated treatment referenced in section 13(4)A. You don't have to remember that because I will provide that change in writing. But essentially what this does is it just acknowledges that point that Kevin made about the age of consent being 13. So right now the law says that the only way that you could otherwise require someone to receive treatment is through involuntary treatment. But by lowering the age of consent to 13, we want to recognize that there's another way that someone in the ages of 13 to 17 can receive that treatment, and that's through family-initiated treatment. So we think it's a small change, but an important one. And we hope that we can help perfect this bill and most importantly, continue the work that we need to be doing here for all the reasons people have talked about. Thank you.
Excellent. Thank you so much, Jacqueline. I think we've already received at least the first 3 of those changes.
Only 3.
And yes, thank you. Next up is going to be Katie Colin.
Thank you so much for having me, Chair and members of the committee. Really a pleasure to be here. And of course, following Jacqueline Greenberg, who is an attorney, I will acknowledge that no, not all physicians are attorneys, but some of them are, but most of them are not. So you'll see that the Washington State Psychiatric Association, we signed in with concerns. I could have easily signed in pro, and so if I could somehow change that on the record, please go ahead and do that. We're really pleased to see this bill. And I know Senator Kaiser, I've spoken with you for a long time about my personal and professional interest in healthcare related decision making and the documents that go along with that. So thank you for bringing this, and a pleasure to be part of the group. This bill creates a role for substance use disorder professionals in evaluating capacity for the purpose of these directives. So we would be requesting a change to make sure that in the situation where we're rendering someone incapacitated, we know that that's a very important job with a profound impact on a person's life. It comes with a lot of risk. So the portion where we're having substance use disorder professionals evaluating incapacity, we'd really like to have a physician on board there. I don't need to bore you with the amount of education and training physicians have. It's all obvious, but we really have to have somebody with some eyes on the medical side of things for determining someone's incapacity. So we'd be glad to work with you. I believe we've put some of our remarks in short form in writing to you, but would welcome that change to have a medical doctor or a DO involved in those transactions. But again, really stoked to see this bill. Thanks a lot.
Thank you for that. And I do know the Law and Justice Committee heard a bill about capacity in the healthcare field. So we'll make sure that those bills actually fit well together.
Thank you, Senator.
Next, I would like to invite Daria Farivar to please come testify.
Hi, thank you, Chair Dhingra and members of the committee. For the record, I'm Daria Farivar with Disability Rights Washington. We have signed in support of 5370. We are really excited to be a part of this work. I think, as you all know, David Lord has been working on this issue for many years, and we appreciate his dedication to it, and it is a priority for DRW. With this bill, we have a couple of changes that we would like to see to make it easier to access for the community. And some of those changes are happening in the form. So I'm going to go through those briefly. The first thing we'd like to talk about, we understand that in the bill, folks are able to either have the advance directive signed by a notary or 2 witnesses. We understand that is clear in the bill. However, we hope that we can clarify that in the actual form itself to make sure that laypersons understand that as well, and we're not unintentionally creating a barrier. We understand that many folks do not have ready access to a notary, and we want to make sure that that is not a barrier for completing an advance directive. In the form itself, we do have some suggestions on where we can clarify the language to make sure it is really accessible and really truly in plain language, again, to make it more accessible for the community completing the form. We'll provide those in written testimony after this hearing. We also have a recommendation for Part 6, subsection D, regarding preferences and instructions about hospitalization and alternatives. We did speak with some peers who are on our advisory councils, and they came up with some great suggestions I'd like to share with you. That includes the option to consult with an agent with the power of attorney designated in this document, another option to consult with an individual with a fill in the blank after that, and then another option to have a referral to a behavioral health ombuds for assistance and for consultation as well. In Part 7, under the durable power of attorney section, we understand that folks making an advance directive may already have an agent governing a different aspect of decision making. We'd like to see a section where that is acknowledged and folks can add information in case that is the case for them. Also under Section 7, under Part D, the form provides the opportunity to nominate a guardian if one is needed, but it only lists the possibility as nominating the agent. it seems like this might be unnecessarily limiting, and we hope to open that up. So if someone would like to have a guardian, that might not be the agent that is possible to list. Also in that same section, folks found it important to identify if there was someone that they do not want to be appointed as a guardian. So if we could add those changes, we'd really appreciate that. Generally speaking, we hope that this form will be accessible to all, particularly folks who use screen readers and are blind. I understand that there are some challenges around doing that electronically, but that some of those simple changes would, again, increase accessibility and availability to advanced directives for individuals. Let's see, in regards to other changes we could be making for implementation and to, again, improve ease of access and make sure that this is really truly effective and used by the community. We hope to have more conversations about creating a registry for those advanced directives so folks don't need to walk around with them in their back pocket and they're easily accessible to those medical professionals as well. Look forward to having more of those conversations. And then lastly, I just want to end by saying I appreciate Laura Van Tosh's testimony, and I really truly believe, and DRW believes, that peers really need to be leading this conversation. So we appreciate their work on the work group. We appreciate their testimony. I apologize, things are going off if you can hear the dinging in the background, and want to make sure that they are leading the way on these systemic changes. So thank you very much for the opportunity to testify.
Thank you so much, Daria. Next up is Carrie Stanberry. And I just hope you're driving safely there, Carrie.
Well, hello. Yes, I am driving and I'm pulling over as you are talking right now. So I am at a red light. As soon as I can turn the corner and stop my car, I will. So thank you for this opportunity, everybody. I have not read the bill, so I really can't talk a lot on it, and I don't have developmentally disabilities. So that's another thing that I would like to say, that I don't know a lot about the things on the bill. However, I do want to speak on the fact of involuntary holds for folks in hospitals that I've had experiences with, as well as the other thing I'd like to conversate with really quick is the opportunity to talk about getting help before it becomes the crisis and needing a bed that's not even available. So I live in Vancouver, Washington, Clark County. I am a 52-year-old woman who has literally spent her 18th birthday in the first mental institute of my life. Throughout my life, I've been in many, many hospitals. Right now in Clark County, July 9th was the last time that I received mental health services. I have been completely kicked out of every mental health service in the Clark County, Vancouver, Washington area. Molina will not find me nowhere to go. I'm 30 days with having no medication that I have been on. One of the meds I've been on for 35 years. The other two I've been on for 12 years. I will have no mental health meds in 30 days. I'm petrified. I'm scared for my life. I'm scared for my safety. I've begged. I've pleaded. I'm in the middle of fair administrative hearing. I have the greatest fear that I'm going to die in 30 days, and not one person in this state will listen to me. Nobody will do anything. Secondly, I will go ahead and talk about this involuntary hold in any hospital. There is no hospital that I've been into in Vancouver, Washington, that I would ever want to go to, ever. They are not trained to deal with mentally ill people. You are subdued, you're held without even going there for a mental health crisis with a medical condition, because you answer questionnaires, mental health questionnaires, truthfully, and they don't even have the training of knowing what to do when you answer them. They put you in mental health hold for no reasons at all. Black and blue arms, as petrified of the hospitals. I am petrified to go to a Clark County, Vancouver hospital, and I don't have nowhere for anybody to titrate me down on medication that I need, that I could die from. When the pharmacist gave me my last prescription, she told me, you need a doctor that will help you. No one will help me, not a doctor, and there are no mental health agencies that will even see me, and nobody will do anything to help me. If anybody can help me, I am scared in 30 days, you guys, that I'm going to wind up back in mental hospitals, jail, or dead. And this is a system that everybody thinks they do such a great job on.
Carrie, Thank you so much for your testimony. I will make sure that someone follows up with you. We will make sure we provide you with resources. I'm sure Laura can help with some peer support. And let's make sure we get you
with me.
And we'll make sure that we reach out to NAMI, Clark County, and make sure we do that. But we have your email address. We'll make sure someone from my office follows up with you, okay?
Kim at NAMI, she won't have nothing to do with me, ma'am. She's the death of me. I'm a state trainer for all NAMI signature programs and state teacher for one of them. And since Kim from Southwest Washington started NAMI, I have not went in there and folded an envelope even. Kim, no.
Okay, we'll make sure you get in touch with some peers. So thank you, Carrie. Thank you, Laura. I'm taking your coming back on camera as an offer to help. So let's make sure we connect you to that, and we'll make sure we connect you. And I just saw a text come in. We'll follow with Melina as well. So thank you for taking the time to participate, and we will do some follow-up in your case. And with that, I will close the public hearing in Senate Bill 5370. Thank you once again to everyone who testified, and thank you so much, Senator Kaiser. We're now going to move into testimony from Senate Bill 5412. Kevin, could we get a briefing from you, please?
Yes, for the record, my name is Kevin Black, staff to this committee. Senate Bill 5412 relates to facilitating supportive relationships with family and significant individuals within the behavioral health system. By way of background, the Healthcare Authority, or HCA, is the state behavioral health authority and manages the community behavioral health system for clients enrolled in the Medicaid program. The Department of Social and Health Services, or DSHS, operates 3 state hospitals for psychiatric treatment: Western State Hospital, Eastern State Hospital, and the Child Study and Treatment Center. These hospitals treat court-committed patients from around the state for periods of 90 days or longer. What this bill does is it requires the Healthcare Authority to conduct oversight of the community behavioral health system in a manner that is aware of, nurtures, and protects significant relationships in the life of behavioral health system clients. It also requires DSHS to administer state hospitals in a manner that similarly is aware of, nurtures, and protects those significant relationships in the lives of state hospital patients. HCA and DSHS are both required to conduct a review of their policies related to allowing and facilitating family engagement in consultation with stakeholders, family members, and peers to identify and eliminate policies that undermine the integrity and health of the family or discourage family engagement. These reviews must be completed by June 30th of 2022. HCA and DSHS are also required to consider principles when administering programs and making policy, including the client or patient's right to have a compassionate, caring family member involved or advocating for their treatment, encouraging parents to be engaged with their children's behavioral health care, avoiding unnecessary trauma to families, including situations involving severance of parental rights, the need for whole family treatment to build, reestablish, and strengthen healthy relationships, the need to closely monitor medication use for children and support parents in those situations, and to employ the legal system only as a last resort. HCA and DSHS are instructed to imply words like parent and family broadly to include a range of relationships where there is a caregiving or mutual support relationship, and including considering the term child to consider a youth up to age 25. A fiscal note has been requested but not received. I would be happy to answer any questions.
Thank you so much, Kevin. Do any of the members have any questions for staff? Seeing none, Senator Warnick, thank you so much for bringing us this bill, and would you like to speak to your bill?
I would. Thank you very much, Madam Chair. For the record, I'm Senator Judy Warnick. I represent the 13th Legislative District, which is in Eastern and Central Washington. There is no question we need more behavioral health care. We need more behavioral health systems and facilities. I heard that loud and clear this morning, especially for our children and youth. I hear constituent stories daily, weekly, monthly, about different families that need help. And I believe there will be testimony today from one of my families in my district. I can see her picture on right now. But I wanted to point out a couple things. I really want to thank Kevin for the great work he has done on this bill. He has spent hours on it. And I'm hoping that we can get the message out that we need to involve our families and our parents. I'm not trying to do a medical mandate for any of the good work that our caregivers give, but I just know there's a gap in connections. And I'd like to point out, I read in my local newspaper just a day or two ago, Governor Inslee has declared February as Parent Recognition Month. Parent Recognition Month. So he's doing that with the Child Magazine out of Seattle, and they are doing awards, Unsung Heroes Award. And I think our parents, our families of mental and behavioral health children, they all deserve that award. And I'm so glad that Governor Inslee is calling our attention to parents and the recognition they deserve. And Madam Chair, I wasn't going to read this, but I just received an email from a young lady, and I was wondering if it would be possible for me to read this.
Absolutely, Senator Warnick.
She is commenting on this bill. I got it at 9:37 this morning. I'm not going to give her name, but she said, I am 12 years old. I have suffered at the hands of my older sister who is mentally ill. She has strangled me, hit me, shoved me into walls, and verbally abused me. I believe the well-being of the whole family needs to be included with the treatment of mentally ill children. I support this bill so that other children do not have to experience what I have. This is from a 12-year-old. So I am doing this for the families that I've been in contact with. I'm doing this for this 12-year-old girl who needs help for her family as well. So thank you very much for hearing this bill, and I look forward to future conversations. Thank you, Madam Chair.
Thank you so much, Senator Warnick. Do any of the members have any questions for the prime sponsor? Seeing none, I would like to invite Penny Quist to please start her testimony.
So I'd like to thank Senator Warnick for giving me this opportunity to bring this bill forward. I'd like to thank Kevin Black for the beautiful way he wrote it, and I'd like to thank this Senate committee for consideration on this bill. I'd like to share two pieces that were pertinent in this bill that just took place in my home this week and really just yesterday. My child discharged from the highest level of care the state has to offer, and that's Child Study and Treatment Center, after 6 months in rehab and other inpatient treatments, and then 18 months in CSTC, which ended when he aged out just because of a birthday candle. He returned home this past Sunday with some of the best discharge planning and wraparound services the treatment team could provide. Then came a glitch. With this glitch, I spent 6 hours transferring records, making appointments, calling many providers, and coordinating care and advocating for him yesterday on his 18th birthday. Some of these providers were difficult to negate, as I'd been left out of that treatment when he was at CSTC because he, quote, could handle it on his own. And he did with the support system that was there. But once he discharged, my child once again needed his mother. Another part of that bill that has been actively used in my home this week is using those tools that we have gained in building, reestablishing, and strengthening healthy relationships that we learned while he was at CSTC and that were given to me by the intensive DBT training, the counseling I sought out on my own, and the wraparound services that our family has been given. This is vital. I had received accolades when I spoke out saying, a child in crisis is a family in crisis. And I was wrong to say that, because what I have should have been sharing with everyone is, a child in treatment is a family in treatment. I'm here to tell you what I've learned and know that through a journey of growth, maturity, and continued knowledge, is that our family is blessed to have these skills. I ask that those of you in this committee understand that a family unit is one of strength and endurance, that as we change how our families are viewed, acknowledged, trained, and used as a resource rather than omitted, criticized, and even blamed, we can move forward as one conducive team and in treatment and care of our most precious, our children and our future. I am thankful, Madam Chair, that you've given me this opportunity, and I ask this committee to consider what is in this bill and to understand the trials that we face and the things that we can do, because we families are strong and we are here to be committed to our children and to continue this work when no one else can do it.
Thank you so much, Penny, for sharing that and for bringing this bill to Senator Warnick. Peggy Delane, you're next.
Hi. Thank you for allowing me to testify. Thank you, Senator Warnick, for allowing me to help in bringing this issue forward, as well as Penny and Kevin Black. It's been a long journey. My name is Peggy Delane, for the record, and I'm a parent advocate. I'm here to testify on behalf of parents and families that have been harmed by our behavioral health system that prioritizes individual rights over family health. Throughout human history, families have been the core sustaining support system for dependent children. Why then does our state healthcare authority and DCYF not include healthy families in their client rights statements? I regularly speak to families who are being harmed by our well-intentioned system that puts children in foster care before giving involved caring parents the ability to intervene in severe mental illnesses. Last year, the Senate and House unanimously passed a resolution to give parents the ability to consent to medically necessary behavioral health care. This morning, at Eastern Washington Family, the family of that 12-year-old that Senator Warnick just read from, is being threatened with child abandonment if they don't take their older child home, who was attempted suicide for 5 times in the last year. The system is supporting the child's right to make this choice while the mental health of the younger siblings have been not taken into consideration. The mother is being told that if she refuses, even with an at-risk youth petition that says jail or treatment, if she doesn't take the child home, CPS is going to take away her medical license, and that family will lose their income and lose potentially their children. I know from my work on House Bill 1874 and 2883 that passing a law doesn't mean changing culture, but this bill is a step in the right direction and reflects evidence-based best practices for adolescent behavioral care and is an equity issue for African American families, other BIPOC families, and families of disabled children who are expected to use a legal system to fight for care when they may not have those resources. Please pass Senate Bill 5412 and please encourage Governor Inslee to understand that our broken system is not helping early intervention with our children, and we are in severe crisis. Thank you.
Thank you so much, Peggy. Next, I would like to invite Daria Farvar to provide her testimony.
Thank you so much, Chair Dingra and members of the committee. For the record, this is Daria Farvar with Disability Rights Washington. We have signed in opposed to 5412. We appreciate and believe in many of the principles stated in this bill, including the idea that families should not be separated unless there are findings of abuse and neglect. However, we oppose this bill because the definitions of family and child are far too broad and could have harmful consequences. This bill proposes the definition of family be changed to include non-relative caregivers. Many people with disabilities hire paid caregivers to address their needs. Caregivers are not necessarily in the position to be making decisions about an individual's behavioral health. They are there to support their independence and self-determination. 5412 also proposes that the definition of child include adults up to the age of 25, even though the age of majority is 18. It also proposes that individuals, regardless of age, who have guardianship also be defined as children. Those who have a guardianship already have a decision-making structure established by the court. And to say that these individuals are children is to take away their dignity and self-determination about their own care and treatment. We are concerned that these changes will open up children and adults to treatment that they do not consent to, diminish their privacy rights, and expose them to potential exploitation. This bill repeatedly puts the burden of revoking consent on the individual rather than the burden of seeking consent on the expansively defined family. This is particularly troubling in the case where an individual may be taken advantage of and have to object to their abuser participating in their behavioral health. In sum, 5412 includes many important values that we do support, but we are gravely concerned that it is overly broad and could expose many people with disabilities to unintended consequences. We urge you to not pass 5412. Thank you so much for the consideration and opportunity to testify.
Thank you so much, Daria. Next is going to be Melanie Smith.
Good morning, Madam Chair, members of the committee. My name is Melanie Smith, and I am here today testifying on behalf of NAMI Washington. And we are signed in other on Senate Bill 5412. We also agree with many of the values and goals in this bill, and we concur that family members and positive relationships are vital to promoting healing and recovery, especially for youth. And when appropriate for an individual, families should be supported and involved. And we have long supported policies that make it easier for families to be involved in care planning and treatment. We've worked with many of these same stakeholders on the family-initiated treatment bill that passed 2 years ago, giving more options to families of youth, and we stand by that important work. But we also acknowledge that patient confidentiality is the bedrock upon which a trusting therapeutic relationship is built. Confidentiality is a core legal principle of patient rights precisely because it is so important to quality and effective healthcare. Balancing confidentiality and that trusting therapeutic relationship and the need for family involvement is one of the reasons why our privacy statutes are so complex. Others can share more on the legal nuance of this, but confidentiality can be a critical element in the very decision to seek services, and this is particularly true of youth. We support the ability of young people to access the services they need, and for some youth, being able to do that in a confidential way is important, and any loss of perceived privacy may function as a barrier to youth and young adults who are only willing to seek services if they are guaranteed privacy. So we are signed in as other on this bill, because even though we acknowledge that there's really great intentions to include families in care, we are worried that some of the deep complexities and nuances in this particular area of law have been thoroughly worked in this bill. And we have serious questions about how this bill would be operationalized within the current legal framework that balances the needs of families and youth and young adults. I thank you for hearing my testimony, and I'm happy to answer any questions.
Thank you so much, Melanie, for that. Next, I would like to ask Katie Colan to please testify.
Madam Chair, members of the committee, hi, my name is Katie Colan. I'm here testifying on behalf of the Washington State Psychiatric Association. I won't belabor some of the points that were made earlier, and I know that our physicians have sensitivities, especially to the families who have come today and spent time with us. Again, we think the intention here is good in that families are obviously supportive and vital, but there are also some bad family situations, and any law involving family really does have to take into account those good situations and those bad situations. That's been discussed before this committee already, so I won't go further. I will also note, though, that clinical judgment should be paramount rather than legislating how these situations should be handled. Again, I don't need to bore this committee with the role that physicians, psychiatrists play here, but we do want to see clinical judgment used in appropriate ways in these types of situations. And I will note that some of the child psychiatrists in our leadership noted that if any of the provisions of this legislation conflict with the Children's Mental Health Work Group or the with family-initiated treatment, then we do have some concerns and questions about moving those elements forward. I do welcome any questions, and thanks for the opportunity to testify.
Thank you. Senator Frost?
I think I can prefer to wait till after the last panelist, and then I can ask a question.
Okay, thank you. Our last person actually is Jacqueline Greenberg.
Thank you, Chair Dangra, members of the committee. For the record, my name is Jacqueline Greenberg. I work on behavioral health policy on behalf of the Washington State Hospital Association. In the interest of time, first, thank you again for the opportunity to appear before you for the next bill on this hearing list. We're here to testify other. a lot of the feedback that was just given on the bill from everyone, I think it's well made, and I don't want to repeat it. What I do want to do is what I want to acknowledge is that while the bill does not directly implicate healthcare delivery, I think or doesn't directly apply to healthcare delivery, excuse me, it does implicate it for the reasons that Melanie just so well put it. One example I want to give to the committee for an example here is if you look at section 2(1)(b). So this is one of the principles that would need to be incorporated into the way that the Healthcare Authority and other agencies think about implying these policies. And it would, in that bill, would create shared decision-making powers and the right to disclose information to family members. This section would create a fourth standard for disclosing healthcare information after the federal HIPAA privacy law, the state's medical privacy law, and the federal law governing the privacy of substance use disorder information and records. I should also add that this section contemplates shared decision-making that conflicts with the healthcare consent statute here. So I raise these examples specifically because I think that while we can imagine how well-intentioned a family-centered approach can be, we can also imagine that it may not be therapeutic for the reasons that Melanie and Daria just spoke to. So, I served as one of the folks who, along with Kevin Black, worked very hard on that family-initiated treatment law so that we were striking the very right balance between empowering our adolescents to seek the care that they may not feel they can get with their family, while also really encouraging loving and supportive, engaged families like Peggy to be able to engage appropriately. And so I think the ask here would be to really think about how we see this filtering down into the delivery of healthcare and invite further discussions outside of the sort of pace of legislative session to really think through what this would look like. I'd be happy to answer any questions. And if it would be helpful, I wanted to offer to this community, I recently wrote a rather long and technical bulletin about disclosure of privacy information that might be a good and useful primer for folks to really think about these issues. Also, if you can't sleep, it would also help with that problem too. So here to help and answer any questions if I can. Thank you.
Thank you, Jacqueline. I do love reading technical stuff, so please do send it to all the committee members so we can share in that. Senator Prock, you had a question?
I do. Thank you, Madam Chair. This may be directed more to Senator Warnick or to Kevin, but just after hearing the testimony and reading the bill and the bill report, trying to get kind of my head around this, certainly understand some of the concerns. I can see the concerns about, a young person up to age 25 and sort of the civil liberties concerns at that point with someone between the age of 18 and 25, or even below that. But I understand in particular how that jumps out. However, I guess my question is for Senator Warnick. As I read the bill, it's really directed at trying to ensure that the families of someone who is suffering, that they have that the effects as to them are mitigated if possible in the way that I don't even know, the treatment or the HCA is looking at their needs. And I guess I'm a little bit, I think that's a really laudable goal. And I'm just kind of curious what am I misunderstanding this? Because as I read the bill, I don't read it nearly as gravely as some of the testimony I'm hearing, but I admit I'm not the expert in this space. Maybe you could respond to what at least you're trying to get at versus what we're hearing.
Yeah, and thank you, Senator Proct. And I am not trying to negate any privacy issues that any of our patients or children might have. What I am trying to do is bring in a family, a parent, other family members, like I read the young lady. I don't think that's the same case that Peggy talked about, by the way. It's two different cases here. But anyway, I am not trying to do that. What I am trying to do is bring in more people that care about those patients and may be able to help. I heard about one this summer the patient was 39 years old, and it took 3 tries for his parents to get him to a facility while he was escalating but it took 3 tries for a doctor to listen to the medication they recommended before he was able to get help. So it's a frustrating situation all the way around. And if I hear about it, I know others are too. But I had a question for Jacqueline. You talked about section 2(1)B. Is that B as in boy or D as in David? That you had some disclosure issues with.
Thank you, Senator Warnick. B as in boy.
Boy, okay.
It's the section referring to 700205. So that language that comes after it creates another layer of standard for evaluating when a healthcare provider could disclose information.
Okay, because the one is the patient does not object, but then you're talking about the next sentence. Is that correct?
It's the language that comes in after the word and. So
okay. Yeah. Okay.
I'm just going to ask all the presenters who had technical fixes to follow up with email, and so we can work on that.
Yeah, I would appreciate that.
Thank you. And with that, we are going to close public hearing on Senate Bill 5412. We are now going to move into executive session. I do want to thank everyone today for all the testimony, and you are free to continue hanging out and watching us do executive session, or you're welcome to watch it on TVW. With that, Kevin, can you please give us a briefing on all the bills on executive session today?
Yes, for the record, Kevin Black, staff to this committee. We have 5 bills on executive session today. The first is Senate Bill 5195, which you heard a couple of weeks ago relating to opioid overdose reversal medication. You have a proposed substitute, Delta, by Senator Dingra, which has the following effect. It expands requirements for hospitals to provide the opioid overdose reversal medication from just patients in emergency rooms to patients also who are admitted to medical floors. And instead of applying to patients who have an opioid overdose use disorder, it's patients who present with symptoms of an opioid overdose, opioid use disorder, or other adverse event related to opioid use. It also requires hospitals in those situations to provide information and resources developed by the healthcare authority to those patients effective January 1st, 2022. It requires Medicaid managed care plans to reimburse providers for this medication for medication provided to Medicaid members. It exempts hospital personnel from charges of unprofessional conduct. It expands the requirement for outpatient substance use disorder programs to provide assistance with medication to include all community behavioral health providers, which would include mental health facilities. It has a similar change to the definition of who this would apply to, people who have symptoms or who report recent opioid use outside of legal authority. It also specifies that these requirements would apply during an intake, a discharge, or during an outpatient treatment plan review. Finally, the bill requires community behavioral health providers to bill the client's insurance and also waives some labeling requirements for dispensing medication directly, although it does require directions for medication use to be provided.
Do any of the members have any questions for staff? Okay, seeing none, if we can go to the next bill, Kevin.
Senate Bill 5071 relates to community treatment teams. We heard this during the first week of session. There is a proposed sub Foxtrot by Senator Dingra, which specifies that the multidisciplinary treatment team shall consist of a specially trained community corrections officer, a representative of the Department of Health Services, and a representative of the Community Behavioral Health Agency for someone who is committed related to criminal insanity laws. The representative of Department of Social and Health Services is not present if the commitment is under the 7105, the Civil Involuntary Treatment Act. There's the court requirements. The court is allowed to omit appointment of the community corrections officer if it makes a special finding that the appointment would not facilitate the success of the patient or the safety of the person in the community. There's direction for the Department of Corrections to collaborate with the Department of Social and Health Services to develop the specialized training for the community corrections officers who would participate in the transition team. It allows the transition team to meet according to a schedule developed by the team. It allows the conditional release planning to start at admission and to be facilitated by state hospital liaisons. It allows the court to delay holding a bail hearing at first appearance or arraignment for a person for whom a competency evaluation will be ordered if charges are pursued, and also applies less restrictive alternative minimum requirements to persons committed for inpatient treatment. I'm sorry, this is a provision that specifies that the provisions of the Act apply to people who are committed for inpatient treatment at the time of the Act. Just to clarify that.
Thank you, Kevin. Do any members have any questions for Kevin? I know this is a very technical bill, and I apologize for that. Any questions? Okay, seeing none, can we get a briefing on the third bill, Kevin?
Senate Bill 6327 is the Senator Brown bill related to creating a youth tip line, which was heard last week. This bill has a much shorter effect statement for the sub-ECHO, which is being proposed by Senator Wagner. And this just allows the court to review the tip line information in chambers outside the presence of a petitioner seeking disclosure of the information, but doesn't require a hearing to be held inside of chambers to review the tip line information. Then there are changes related to the fund, which allows the Attorney General instead of the State Treasurer to receive money or assets to fund the Yes tip line, and allows the Attorney General to convert assets to cash if they're received in support of the tip line.
Do any of the members have any questions for Kevin on that amendment? Proposed sub. Seeing none. Okay, moving on to the next one, Kevin.
Senate Bill 5236 is the Certificate of Need Exemption bill brought forward by Senator Warnock, which was heard last week. There is a substitute Bravo proposed by Senator Warnock, which just clarifies language to make one of the exemptions clear that psychiatric hospital could add either 30 psychiatric beds for long-term patients, 30 psychiatric beds for short-term patients, or both. It also changes references to 72-hour detention to 120-hour detention to conform with the bill passed last year. I'd be happy to answer any questions.
Any questions for staff on this bill? And the last bill on exec today, Kevin.
Finally, Senate Bill 5328 is the bill you heard last week relating to clubhouse services, sponsored by Senator Lovelet, and this bill has no amendments.
Excellent. Do you think we need to caucus for about 3 to 5 minutes, Senator Wagner? I hope you can be fairly quick.
I will not guarantee 3 to 5 minutes, but we do need to caucus.
Okay.
I know we're running long, but these are important topics. So.
They are. We will now break for caucus, and hopefully it'll be resolved within 5 minutes, but we'll try to do the best we can. Thank you. Everyone for coming back quickly, though I don't think we'll be able to finish in 1 minute. We can certainly try. And so moving us right into executive session, we have Senate Bill 5195 before us. There is a proposed substitute Delta offered by me. Senator Wagner.
Madam Chair, I move adoption of the proposed substitute Delta.
It has been moved and seconded that the proposed substitute be adopted. Is there any discussion? And I'm just going to start. Oh, thank you, Senator Wagner. I'll just start by saying that I do believe this is a very important bill that Senator Elias has brought to us. There've been a couple of meetings in trying to make sure that everyone has come to the table and can move forward in a way that makes sense. I had a meeting yesterday with the hospitals and the physicians, and while this is not where they are comfortable with the bill yet, we had great conversations, and I actually have no doubt that we can get there at Ways and Means. So I am going to actually hope to get your support to move this bill out of this committee so that we can continue to work to perfect the bill. And I really do believe that we are very close to making sure this gets done. Senator Wagner.
Yeah, thank you, Madam Chair. So I've been pretty transparent in telegraphing that I want to get to a yes on this bill because people are dying. And I think there's a way to save lives through this bill. The proposed substitute, though, diverged. I think we got further away. And so I'm recommending a no vote on the proposed substitute. I think the underlying bill is the place to start to continue working this bill forward. So I'll be asking for a no to the proposed substitute.
Thank you, Senator Wagner. I will be asking for a yes. So all those, so members, please unmute yourself. All those in favor say aye.
Aye.
Aye, and raise your hands. I think it's just easier that way too. Sorry, we did that in law and justice, and I just assume we do that here too. All opposed say nay, and please raise your hands.
Nay.
Okay, the ayes have it. The proposed substitute is adopted. Senator Wagner?
Oh, okay. Never mind.
It's okay. Madam Chair, I move the proposed substitute receive a due pass recommendation and be sent to Ways and Means Committee.
Thank you. Is there any further discussion on final passage? Okay. Yes, Senator Wagner.
Because I believe that we have gotten farther apart on that due to the proposed substitute, I'll be voting no rec today. I hope that we make the changes either in a further committee or on the floor, and I really want to support this and bring support from my caucus on the bill. So let's all work hard to get there, please.
Thank you so much, Senator Wagner, and I'm very optimistic that we will. With that, if there's no further discussion, staff will call roll.
And for all these bills, your choices are aye, nay, and without recommendation. Dingra?
Aye.
Wagoner?
Votes no recommendation.
Frocht?
Aye.
Nobles?
Nobles votes aye.
Warnick?
Without recommendation.
I'm supposed to share my, oh yes, sorry, just a second. Madam Chair, there are 3 ayes, 2 without recommendation.
Any member wish to change their vote? Seeing none, Senate Bill 5195 has received a due pass recommendation and is sent to the Ways and Means Committee. We now have Senate Bill 5071 before us. There's a proposed substitute Foxtrot by me. Senator Wagner?
Madam Chair, I move adoption of the proposed substitute Foxtrot.
It has been moved and seconded that the proposed substitute be adopted. Is there any discussion? I'll just say that this proposed substitute took a couple of weeks to work out because while talking about this bill, we actually discovered a problem with care coordination issues on civil commitment. And so we decided to take this opportunity to work through all of these issues. And I do want to thank everyone for coming together on the substitute. Hearing no further discussion, members, please unmute yourself. All those in favor, please say aye and raise your hand. Aye.
Aye.
All opposed, say nay. The proposed substitute is adopted. Senator Wagner.
I move the proposed substitute receive a due pass recommendation and be sent to Ways and Means.
Is there any further discussion on final passage? Okay. Seeing none, staff will call the roll.
Dingra?
Aye.
Wagoner?
Aye.
Frocht?
Aye.
Nobles?
Nobles votes aye.
Warnick?
Aye.
Madam Chair, there are 5 ayes.
Does any member wish to change their vote? Seeing none, Senate Bill 5071 has received a due pass recommendation and is sent to the Ways and Means Committee. May we have Senate Bill 5327 before us? And there is a proposed substitute ECHO by Senator Wagner.
Madam Chair, I move adoption of the proposed substitute ECHO.
It has been moved and seconded that the proposed substitute be adopted. Is there any discussion?
And Madam Chair, this was a amendment that was worked and agreed to by the bill's sponsor, and it provides some protection, I think, by limiting how a hearing can be held and who gets to be in on that, and it also provides some language on where the funds are kept.
Thank you so much, Senator Wagner. Everyone, members, please unmute yourself. All those in favor say aye and hold up your hand. Aye. Any opposed? The proposed substitute is adopted.
Madam Chair, I move the proposed substitute receive a due pass recommendation and be sent to Ways.
Is there any further discussion on final passage on this bill? Senator Frocht.
Thank you, Madam Chair. Just thank you, Senator Wagner, for working on this. I spoke with the bill sponsor last night as well, and look forward to working with you and maybe have an idea or two to help us get this thing into place. So look forward to connecting with you on this as we move forward. But thank you for your leadership.
Excellent. I look forward to that.
And I'll just add that I'm just going to be without recommendation only because we heard testimony from the Attorney General's office that they don't necessarily want to do this body of work. I think this tip line is extremely important, and I'm really hoping that we can find a solution there. And I think that's exactly what Senator Frocht was alluding to. So I am so sure we will get there again, because I do tend to be an optimist, but that is the only reason I will be voting without rec and moving this on to Ways and Means. The other members of my caucus will be in favor of this. So with that, seeing no other discussion, staff, can you call roll, please?
Ingra.
Vote without rec.
Wagoner.
Votes aye.
Frocht.
Aye.
Nobles.
Nobles votes aye.
Warnick.
Aye.
Madam Chair, there are 4 aye votes and 1 without recommendation.
Does any member wish to change their vote? Seeing none, Senate Bill 5327 has received a due pass recommendation and is sent to the Ways and Means Committee. May we now have Senate Bill 5326 before us. There's a proposed substitute Bravo by Senator Warnick.
Madam Chair, I move adoption of the proposed substitute Bravo.
It has been moved and seconded that the proposed substitute be adopted. Is there any discussion?
Yes, Madam Chair, this is an amendment that was brought by the Hospital Association, who initially brought the bill to me. It was more of a clarifying amendment.
Thank you so much, Senator Warnick. Yes, this is absolutely an amendment that is needed. If there is no other discussion, members, please unmute yourself. All those in favor, raise your hand and say aye. Aye.
Aye.
All those opposed, say nay. The proposed substitute is adopted. Senator Wagner.
Madam Chair, I move that the proposed substitute receive a due pass recommendation and be sent to the Rules Committee.
Is there any further discussion on final passage? Seeing none, staff, will you please call the roll?
Dingra.
Aye.
Wagoner.
Wagoner votes aye.
Frocht.
Aye.
Nobles.
Nobles votes aye.
Warnick.
Aye.
Madam Chair, there are 5 aye votes, 0 nays.
Does any member wish to change their vote? Seeing none, Senate Bill 5326 has received a due pass recommendation and is sent to the Rules Committee. May we now have Senate Bill 5328 before us?
Madam Chair, I move Senate Bill 5328 receive a due pass recommendation and be sent to Ways and Means.
Is there any discussion? Okay. Seeing none, staff, can you please call roll?
Dingra.
Votes aye.
Wagoner.
Wagoner votes aye.
Frocht.
Aye.
Nobles.
Nobles votes aye.
Warnick.
Aye.
Madam Chair, there are 5 ayes, 0 nays.
Does any member wish to change their vote? Seeing none, Senate Bill 5328 has received a due pass recommendation and is sent to the Ways and Means Committee. And that concludes our executive session for today. I really want to thank the members for staying an extra 10 minutes to get us to finish doing this important work. And thank you, staff. And that adjourns our meeting for today. Thank you.
Thank you.
A nice weekend.